The end of minoxidil as we know it is just around the corner. And this is excellent news because today science tells us two clearer things. First, that this magic pill that some doctors prescribe like candy is no more effective than the topical format. And second, that the cardiac risks from infusions to pericarditis are real and documented by the FDA's database. But what if I told you that there's a way to achieve superior efficacy to topical minoxidil without playing Russian roulette with your heart? Today we're going to analyze the definitive results of BDPHL01 and another new version of minoxidil that ends the very traditional oral minoxidil forever. Stay until the end because the data published this past April 27th could change your treatment forever. Since the New York Times published this article in August 2022, oral minoxidil became the trendy drug to treat alopecia. Suddenly, everyone wanted this magic pill. However, the misinformation we've seen on the media and on social networks has been staggering. This drug has been sold as a new miracle, but the scientific community has always had an undeniable truth on the table. The version of oral minoxidil we use today is a drug with an efficacy that does not surpass topical minoxidil and carries a cardiovascular risk that many so-called experts have preferred to ignore. Included in this group of experts is an alarming number of doctors who have been prescribing oral minoxidil like candy for years, without alerting their patients to the severity of its potential side effects. If you're a follower of the channel, you know exactly what I'm talking about. However, if you're new, you should know that the use of oral minoxidil in low doses can cause pericarditis and pericardial effusion, making this drug without a doubt the most dangerous drug a person can use to treat alopecia. In response to these terrible side effects, drugs like BDPHL01 emerge, aiming to increase the efficacy of minoxidil and eliminate its systemic impact. In a 1981 study that analyzed more than 1,800 case reports, 4.8% of patients who used traditional oral minoxidil suffered pericardial effusion. Of these 91 patients, 21 suffered cardiac tamponade, and 8 patients died because of it. Furthermore, this study analyzed 37 patients, of whom 9 suffered pericardial effusion and 1 suffered pericarditis. In these 10 cases of pericardial disease, the authors found that the use of oral minoxidil played a causal role in 3 of them, including the case of a man who used 5 mg daily of oral minoxidil. Echocardiography revealed a significant effusion in 2 patients, and in 4 others, a small posterior effusion was observed, which had no clinical significance. All patients in this study used Lonatin, and not a compounded formulation of oral minoxidil. I say this because some doctors who deny the severity of oral minoxidil's side effects rely on the claim that these effects only appear with high doses, and that the problem lies in using compounded formulas where the pharmacist makes a mistake and uses a concentration 10 or 100 times higher than it should be. According to the authors of the study, the patients who suffered pericardial effusion did not present specific characteristics that help predict the likelihood of experiencing this condition. Furthermore, the authors point out that since this reaction is idiosyncratic and potentially fatal, the use of oral minoxidil should continue to be limited. An idiosyncratic reaction is one that does not depend on the dose of the drug. Therefore, if pericardial effusion is an idiosyncratic reaction to oral minoxidil, it can appear even when used in very low doses. In addition, we have recent evidence of these types of side effects from the use of low-dose oral minoxidil. Specifically, we have 3 case reports published in 2022. A 40-year-old woman who used 0.25 mg daily for 3 weeks and suffered pleural and pericardial effusion. Another healthy woman who suffered pericardial effusion a few weeks after starting treatment with 1.25 mg of oral minoxidil, and the case of a 52-year-old man who suffered pericarditis and peripheral edema after 2 weeks of using 2.5 mg of oral minoxidil to treat androgenic alopecia. Moreover, as the prestigious Dr. Gupta points out in a 2025 study, after conducting a pharmacovigilance analysis using the FARS, the FDA database, they found a clear warning signal. The use of oral minoxidil at low doses is significantly associated with the risk of pericardial effusion even at the lowest doses. The data from this study shows that the risk is specifically high in patients with prior heart problems. But the most concerning thing is that the danger signal remains even in healthy patients. For example, at doses of up to 1.25 milligrams, the probability of reporting a pericardial effusion was 16 times higher than with other drugs, reinforcing the theory that these reactions might be idiosyncratic and not strictly dependent on a high dose. Therefore, as Gupta points out, the evidence of serious side effects at low doses mandates extreme caution. In the absence of long-term safety studies, oral minoxidil should always be used at the minimum effective dose, preferably below 5 milligrams per day, and under strict medical supervision, performed by a cardiologist. If your dermatologist prescribes oral minoxidil and does not ask for a baseline or follow-up electrocardiogram, specifically knowing that there are risks of cardiac events even at low doses, you should seriously question whether this doctor relies on science to treat their patients. And while we're talking about doctors who do not inform the patients well, if what worries you is not the heart, but the side effects of finasteride or dutasteride, I have published the most comprehensive book on this topic, which will answer any questions you may have and help you make an informed decision. I'll leave the link in the description. To understand why BDPH-LO1 is so important, we must first understand the failure of traditional oral minoxidil. The fact is that traditional oral minoxidil has not proven to be more effective than 5% topical minoxidil at any analyzed dose, including 5 milligrams. In a 2023 peer-reviewed blinded study of 23 men and 42 women, 5% topical minoxidil showed a better overall therapeutic effect than 1 milligram of oral minoxidil, although the difference between the two groups was not statistically significant. On the other hand, as pointed out by this 2024 randomized controlled clinical trial, which analyzed 68 patients for 24 weeks, the 5 milligram dose of oral minoxidil is not significantly more effective than 5% topical minoxidil. 5 milligrams is the highest dose of oral minoxidil analyzed in clinical trials to treat alopecia, and this dose, which carries a higher cardiovascular risk, is no more effective than 5% topical minoxidil. In fact, the conclusion of the latest systematic review meta-analysis comparing both treatments published in April 2025 is definitive. Both oral and topical minoxidil promote hair growth. However, according to our results, topical minoxidil may be associated with greater improvement in hair density and fewer side effects compared to oral minoxidil. As I say, oral minoxidil at doses of 5 milligrams or less is not only no more effective than 5% topical minoxidil, and whoever says otherwise is lying, but also the person using it is playing Russian roulette with their health. This is why we have several ongoing investigations aiming to find an alternative to oral minoxidil that allows for increased efficacy while reducing its systemic impact. In this context, the studies of Dr. Shapiro appear, the latest published just a few days ago. The first was a phase 2 investigator-blinded retrospective study that compared the efficacy of 5% topical minoxidil, 5 milligrams of immediate-release oral minoxidil, the traditional one, and BDPH-LO1, a new extended-release oral formulation, in 87 patients. In this study, the use of 8.5 milligrams twice a day of BDPH-LO1 achieved a 2-point improvement in the frontal area and vertex in the investigator's global assessment, compared to 0.5-point improvement in the frontal area with 5 milligrams of traditional oral minoxidil and a 0.29-point improvement with topical minoxidil. Both of these last treatments were used for 6 months. While the difference between the traditional oral and topical minoxidil groups was not significant, the patients who used BDPH-LO1 obtained significantly better results than those who used both traditional oral and topical minoxidil. These differences were even more pronounced in the vertex area, where BDPH-LO1 was almost 4 times more effective than traditional oral minoxidil, with 82.8% of patients achieving clinically significant improvement, compared to 21.6% in the traditional oral minoxidil group. Although hair counts were missing in that study, the latest study published a few days ago does provide this information. One of the most interesting points of this first human study is the use of a 70 mg daily dose of extended release oral minoxidil versus 5 mg of traditional oral minoxidil. This is precisely what allows BDPH-LO1 to potentially be more effective than topical minoxidil. It allows for much higher oral doses than 5 mg. And in its first human study, none of the 33 patients who used 70 mg daily experienced serious side effects. Now, the pharma company Veradermics has just published the results of the phase 2 to 3 study on BDPH-LO1. The interesting thing about this hybrid study format is that it allows the doses analyzed in phase 2 to be validated continuously in phase 3. Therefore, in this trial, 2 concentrations were evaluated: 8.5 mg in a single dose and 70 mg administered in 2 doses of 8.5 mg. You might be wondering, this hybrid format allows the study to be designed as a single continuous process with 2 parts. First, in phase 2, different doses are tested in various groups of patients, and an interim analysis is performed where an independent committee reviews the data and selects the most effective and safest dose. Although in this case, both doses moved on to phase 3. Subsequently, in phase 3, the patients already in the study with the chosen dose continue, and many more new patients are added to complete the number needed for the FDA approval. In this case, all phase 2 patients were included and 432 more people were added. Specifically, this study analyzed 519 men with mild to moderate androgenic alopecia for 6 months. The patients who used BDPH-LO1 once a day gained an average of 30.3 hairs per centimeter square, and those who tried the drug twice a day gained 33 hairs per centimeter square. These data are significantly better than the placebo group, which only saw an increase of 7.3 hairs. A statistical significance was observed starting from the second month, and between 80% and 86% of patients noticed a visual improvement. Traditional oral minoxidil, Lonaten, hits the blood all at once, increasing the risk of cardiovascular side effects such as tachycardia and edema. BDPH-LO1 uses a gel matrix technology, so the drug is absorbed slowly and constantly. According to Veradermics, this maintains the drug above the growth threshold for longer, without reaching dangerous concentrations for the heart. The most important thing about this latest study is that the adverse events of BDPH-LO1 were similar to placebo. No serious cardiac events were recorded. Therefore, this new drug solves the main problem of oral minoxidil. Veradermics expects this new drug to allow doctors to prescribe higher doses of minoxidil, moving from the low doses used to date up to 5 mg to a standardized and safe dose of 8.5 mg. It's worth noting that the main concern of Dr. Shapiro, the person leading this research, is the risk of adverse cardiac events. He explains that the period of greatest risk with immediate release oral minoxidil occurs with a peak concentration in the blood in the hours following the dose. Dr. Shapiro's research is designed to avoid these peaks and valleys, keeping systemic levels of the drug below those associated with adverse cardiac events. And Dr. Shapiro himself had to deal with a significant adverse cardiac event in a patient in his own practice due to the use of low-dose oral minoxidil. In short, this new version of oral minoxidil was created out of concern in the scientific community regarding the side effects and the need to create an alternative for those who prefer pills over topical application. Aside from this extended release version, science is opening another door: the new formulation of sublingual minoxidil. Currently, we have a phase 3 multicenter study evaluating the efficacy of 2.5 mg tablets that dissolve under the tongue, taken twice a day, totaling 5 mg daily. Why is this revolutionary, you may ask? Very simple. When you swallow a pill, it passes through the liver. This is the first pass effect. If your liver does not have enough of the sulfotransferase enzyme, minoxidil does not convert into its active form, minoxidil sulfate, and consequently it won't be effective. Something very similar to what happens with topical minoxidil in people with low enzyme activity in the follicles. The sublingual route enters the blood directly. It skips the pass through the liver. It's more predictable, acts faster, and could offer greater stability compared to the traditional oral pill. In other words, sublingual minoxidil could turn non-responders into patients who finally see results, regardless of their hepatic genetics. This is the second nail in the coffin for traditional oral minoxidil. However, between these two, VDPH-LO1 is the most promising, as everything points to it allowing higher doses of minoxidil safely, increasing efficacy while also appearing to have a safety profile identical to placebo. It's worth noting that if VDPH-LO1 or even sublingual minoxidil ends up being approved by the FDA, we would be looking at the first non-hormonal oral treatment in history specifically approved to treat alopecia. These are two really interesting investigations that could provide a definitive solution for those who prefer oral minoxidil but avoid it out of fear of side effects. Now, if you're considering oral minoxidil because you see no improvement with the topical version, before making the switch, you have to watch this video.